Good afternoon. My name is Dr. Joseph Cardenas from Yuma, Arizona, and today's talk is supported by an educational grant from Cordis, a Cardinal Health company. The topic is radial access, a comprehensive review of clinical applications, techniques from the radial artery. Our presenter is Dr. John George. Our learning objectives are to evaluate and identify transradial approaches for PCIs, to assess the approaches to complex, large bore access cases from the radial artery, and to determine the appropriate access techniques, and to analyze access and closure devices for optimal patient outcomes. And I'll now turn the presentation over to Dr. George.
Dr. Cardenas, thank you for having me here. It's a pleasure to talk through this important topic of radial access and where we find this utility in the complexity of cases that we do. I like to kick it off with a quote from Sir James Mackenzie, and I love this quote, and it becomes applicable to evolution of technology. There are 3 stages in the history of every medical discovery. When it is first announced, people say that it is not true. Then a little later, when its truth has been borne in on them so that it can no longer be denied, they say it is not important. After that, if its importance becomes sufficiently obvious, they say that anyhow, it is not new anymore. And this is the cyclical pattern of what we do when new technology and new discovery comes around, and till it's not new anymore. So with that, we're focusing on radial artery access. And there's a reason why this has become very popular and favorable. And if you know the radial artery anatomy, we know that some of the advantages are that it is superficial, it's easily compressible, it is not a terminal artery because it ends in a palmar arch and connects with the ulnar artery, supplying a dual supply to the wrist. And so this becomes important in utilizing this as an access point as opposed to some other arteries. And where did this all begin? I think Sir Stig Radner, a physician from Sweden, was the first one to actually utilize a radial artery for access, and it was for a diagnostic thoracic aortography that he performed from a radial access. And that first publication in 1947 is what spurred the evolution of using radial artery as an access. And from a diagnostic access point, it soon became an interventional access point when Dr. Ferdinand Khimnezhi actually used the radial access for a stent implantation with the original Palmas-Schatz stent in the coronaries, and this was published in 1993. He did the procedure in 1992. And we've come a long way from there because it started with a diagnostic procedure and then an interventional procedure in the coronaries. And as we go through this talk today, we'll talk through various scenarios where we can potentially use radial access. So I'll start off with the first case, which is a transradial access in an acute coronary syndrome for percutaneous coronary intervention. So here we have an 82-year-old male with no prior medical history that presented with substernal chest discomfort for 5 hours prior to arriving at our institution. The ECG demonstrated ST segment elevations in the inferior leads. And then the patient was urgently transported to the cardiac cath lab for coronary angiography and subsequent intervention. And if we open this up for discussion here, the question becomes, what is your access point in a scenario such as this? Dr. Cardenas, do you have comments on how you approach an acute coronary syndrome?
I think radial first is already a known practice. I like radial first. I think that if the patient becomes hypotensive and has other issues and requires assist, you still have the femoral access for a balloon pump or for Impella or another support device. But radial first it's proven, it's already a known commodity. And I'm excited to see what you show now in the angiogram.
Yeah, so in our lab, we go radial first for all our acute coronary syndromes. It was a learning curve, obviously, for our lab, for our staff to get comfortable with prepping the patient for a radial access, even in an urgent catheterization procedure such as this. But it was a quick turnaround once that learning curve was established. You realize that almost anything that needs to be done during an acute coronary syndrome can be performed from the radial axis. That is not to say that you don't have unsuccessful cases where either the patient is in shock and the arteries are clamped down and you can't access the radial artery, or there's an anatomical variant where there's a radial loop or tortuosity that prevents you from getting through quickly enough to do the case. And so you would have to switch over to a femoral approach or an alternative axis approach. But generally speaking, majority of these cases can be done from a radial access point. And that's what we've converted to as our first option. And so this is the radial access with a diagnostic angiogram showing, on the left panel, showing an acute thrombotic occlusion of the mid-RCA, which was easily wired. If aspiration needs to be done with thrombectomy, that can be performed from that radial axis as well through a 6 French guide. Guide extenders can be used with guidezillas or guideliners or telescope to provide additional support when you don't have that in these lesions, to treat these lesions, and balloon angioplasty and stent obviously can be performed easily as well. And so as you can see, we had a great result from
That's very nice.
stenting. So we'll move on to some data on a broad meta-analysis of patients that underwent coronary angiograms, both in acute coronary syndromes and in stable ischemic heart disease. And what you'll see on the top panel is a combination of all the studies that have been done looking at radial versus femoral access and looking at major bleeding. And you'll see that if you include stable ischemic heart disease and ACS, there's a huge favor towards radial access or radial approach for these procedures. The bottom panel looks at specifically ACS, and even in that subset, you see that there are so many more studies focused on just ACS patients alone, and you'll find that there's a significant benefit in radial access compared to femoral, and that's purely looking at an outcome of major bleeding. All right, so we'll go to another subset of patients. So these are ostial coronary lesions. So using transradial access in these specific subsets, one of the reasons why I wanted to demonstrate a case for this is because people tend to consider ostial coronary lesions, whether it be the left main or the RCA, as a technically more challenging technical case than would be a routine de novo lesion in the mid-vessel or proximal vessel. And so here is a 73-year-old female with history of diabetes, hypertension, and dyslipidemia that presented with exertional anginal symptoms. A stress test revealed inferior ischemia and was subsequently scheduled for coronary angiography. And so we'll talk through this here. If you look at that left panel, you see a calcified RCA that's dominant with an ostial lesion that's about 80% and calcific. You can see that little rim of calcium, shelf of calcium at the superior end of the ostium. That was very easily treated, as you see on the right panel, with wiring, ballooning, and even using specialty balloons such as scoring balloons or cutting balloons to treat the calcium in that vessel and get adequate stent expansion. Again, as mentioned previously, you can use additional support as needed with guide extenders if it is required in the case, but it can easily be treated, even with a second wire if you need additional support in these ostial lesions, with withdrawal of the guide as necessary to make sure that the ostium of the vessel is covered.
That's a great case. What size guide did you use?
Yeah, so this was a 6 French guide. We felt like this was a case that we could treat with the equipment that we needed with just a 6-French guide, with just balloon angioplasty and stenting.
Do you use side holes?
Yeah, so for osteal lesions, we tend to use side holes, side hole catheters. I can't specifically remember if this was a side hole catheter, but there's a good amount of contrast coming out, which suggests that it might have been a side hole catheter. But that tends to be the case in majority of the osteal lesions, since we have dampening of pressures. And the real reason to use side holes in those scenarios is that you have an exit for the contrast that you inject when you're damped from the guide sitting up against the lesion at the ostium.
How do you deal with the possibility of watermelon seeding with an osteal lesion and stent deployment on a radial case?
That's a great question. And so the question is whether we can position the stent or the device appropriately at the ostium without shifting that deeper into the vessel or out into the aortic, into the aorta. And so there's a couple of different techniques that you can use. You can use a second wire that you can potentially loop in the aortic cusp, in the right coronary cusp, if that's where the RCA originates, and allows you to delineate exactly where the true ostium of the vessel is. We tend to do a lot of imaging, and we'll co-register with imaging to find out exactly where the true ostium is, and that helps as well to mark the true ostium of the vessel. Alternative strategies, we actually, to make sure that the ostium is covered, will protrude the stent out into the aorta and then use other specialty balloons such as the flash osteoprobe balloon, which allows you to flare the stent struts in the aorta and allows a good seating of the stent covering the ostium of the vessel.
That's great.
All right, so that brings us to other complex lesions, lesion subsets, and this is transradial access in a left main bifurcation lesion. And so these tend to be complex as well, bringing into question the need for multiple wires, multiple balloons, simultaneous balloons, and perhaps even multiple stents. And so this is a 62-year-old male with history of hypertension that presented with exertional angina and dyspnea on exertion as the clinical symptoms. The stress test was positive for anterior and infralateral ischemia and was subsequently scheduled for coronary angiography. And let me ask you a question, Dr. Cardenas. Is in left main bifurcation lesions, is that a set that you would consider using radial access, or is that preemptively?
I think you're already pushing, and that's good. I would do as many cases as I can from the radial access. With the extenders and the novel technologies out there, sheathless, allowing you, like you mentioned earlier, a large bore guide. It's shorter distance. There's less scratching of the aorta and the iliacs or the arch. And if you have support and they're hemodynamically stable, I'd like it. I shy away from the left main distal bifurcations unless there's clinical evidence I'm a little bit older than you and like to stay away from the bifurcation, but bifurcation is done frequently now. My favorite used to be the osteal. I think that if it can be done from radial, we should try it first.
So that's kind of the path that we follow as well with these cases. These are potentially patients that were either ruled out for a surgical bypass because of their comorbid conditions. If the surgical option is excluded and if this needs to be done percutaneously, what this is supposed to demonstrate is really that it's feasible to use transradial access for even complex lesions. So what you'll see in these panels of pictures, you'll see that there's a distal left main osteal LAD, osteal circ lesion. So this is a Medina 111 for classification of the bifurcation lesion. And this becomes tricky because you have to have a wire into each of those major branches. You need to balloon both of those branches and then decide what kind of stent strategy you're going to use for this bifurcation subset if you're doing this percutaneously. So in this particular case, in panel C, you'll see the stent being lined in the circumflex while there's a balloon positioned in the left main into the LAD simultaneously to allow nailing the ostium with the T-stent technique by inflating the balloon and allowing the stent to be deployed right at the ostium of the circumflex. And then subsequently, after the circumflex stent is deployed, the left main and the LAD can be treated as needed with balloon angioplasty and stenting, which was done in this case, all from the radial approach. And then what you see is a final kiss, a double simultaneous kiss of the LAD and the circumflex from the left main after rewiring the circumflex through the freshly deployed left main and LAD stent to allow a beautiful new carina with brisk flow and widely patent as demonstrated. Now, in all of these cases, we use intravascular imaging. It was beyond the scope of everything that we could show here, but we do intravascular imaging for all of these cases with either IVUS or OCT to demonstrate one positioning, to show adequate coverage, and then adequate stent expansion and apposition, both sizing it before the stent is deployed and also opposing the stent appropriately after and post-dilating after the stent is deployed, and allows you to get a great outcome. The one other thing I'd point out is once you're going into two stent strategies with bifurcation lesions, you have to always think of a larger guide. And so the way we overcome that from a radial standpoint is either using a sheathless guide system, and there are several out there, using slender sheets, which are one French size smaller than the typical standard sheets, allowing you the lumen of a larger French size. Or the third option is using the railway system from Cordis, which allows you to change use any of your guides as a sheathless access for intervention. And it allows you to use a large guide without necessarily creating a larger arteriotomy in the radial artery.
The railway is really a game changer. It allows you to use, like you said, the large bore guide. You have to be more patient, making sure it seats well into the target vessel. But if it's seated well, and you don't have to torque anymore, and you don't have to seat it or play with it, then you're done. And we've had nothing but success with the railway. Our difficulty is in maneuvering it with inexperienced operators and having the hands on it, always wanting to control the guide. The guide should be left alone. It's seated very well there. And if you take the time to choose the right guide, this railway has nothing but success.
That's great. That's what we found as well. And it gives you the flexibility of using your traditional guides that you normally use, as opposed to finding or settling for a curve that's available on the sheetless systems. So it's a good way to use your currently used guides.
We even use railway for coronary interventions and then flip over to maybe do a peripheral distal outflow system, all keeping the initial stick to a 5 French sheath at the end of the case, which is, as we all know, great for these patients that are calcified, elderly, and at risk for vascular complications.
Absolutely. So we elevate the complexity of interventions with this next case. This is transradial access in CTO PCI. So we all know that chronic total occlusions are a complex subset of patients to treat, especially from the radial axis, and sometimes requiring dual access, which could be dual radial or single radial and ephemeral or bilateral femorals. So what you'll see here is a 63-year-old male with no prior medical history that was actually admitted with an acute MI. Coronary angiography that was done urgently at the time revealed thrombotic circumflex occlusion, which was appropriately treated successfully with a drug-eluting stent, and that was done via right radial artery access, which is traditionally done in our labs. But in the process, the patient was also found to have an RCA CTO, which was classified at a JCTO score of 2, which is reasonably complex. And so the patient was discharged after recovery from the acute MI and scheduled for a staged elective CTO PCI of the RCA. So herein comes another discussion point about, how do you approach chronic total occlusions and PCI for this subset of patients, whether you go with radial access, femoral access, biradial or bifemoral, or one of each. And so those are a variety of different options, and I think for most people, what makes that decision for them is the size of the guide that you're going to use for the dual simultaneous angiography. And our transradial access has evolved, and the technology and systems have evolved to the point where, as we discussed in the previous case, the sheathless guides and the railway system allow you to use the larger guides from the radial approach without difficulty. So this is the left panel shows the dual simultaneous angiography in the CTO patient. As mentioned, it was an RCA CTO. There is a guide from one radial that is integrated into the RCA, and then you have a guide from the contralateral radial that is the donor vessel with the collaterals from the left system supplying the distal RCA. So what you see in that left panel is a proximal RCA occlusion, that's a CTO, with reconstitution of the distal RCA via collaterals from the LAD septals, supplying the RPDA and RPL branches. And panel B shows you how this can be traversed retrograde from the LAD septal collaterals. And what you see there is a wire going through the LAD septals into the distal RCA and now retrograde across the occlusion into the proximal RCA. And so if I keep going, in panel C is where you see the loop that is being formed from the left donor vessel collateral into the distal RCA and coming back up and around into the proximal RCA to create that loop, then which allows you to then deliver all your equipment integrate once that wire is externalized and treat that CTO all from a biradial access approach. And so in panel D, you see a final result with multiple overlapping stents to cover that chronic total occlusion with an excellent result to the distal RCA.
That's a great case. That really is a good case. So you used this, what did you use for the left? Was it a 5 or a 6?
So we tend to use a 6 French
for
the left and a 7 French for the...
That was from the left radial.
That was from the left radial was the 6 French, and then the 7 French from the right.
And how do you position the arm, the left arm?
So we bring it towards the body, so it's easier for us as an operator. Otherwise, you have to have somebody sitting, further out if the arm is stretched out. So we bring the arms towards the body, and so it's easier for us to deliver equipment and work seamlessly without changing the style of how we do the procedure. We also have a technique of bringing it up and over the abdomen to give us closer access to the access site, so we're not leaning over with lead and creating bad posture in the cath lab. So this, again, demonstrates how you can even do the most complex of coronary cases by using radial access and using the technologies that are available now to go larger sizes. CTO is a prime example of such a case. Here's some data on looking at CTOs and again looking at the success rate of doing transradial versus transfemoral. And you'll see that there is majority of the cases in a JCTO score that's low is done transradial, but as you go to a higher JCTO score of greater than 3 is when it gets very complicated to do a transradial for a variety of reasons. And I think we're just getting to the point where we are starting to get more comfortable doing complex cases with the radial approach and allowing you to overcome the deficiencies that we have from a radial access, which used to be a size limitation and support limitation. And I think the sizes are overcome now with using the sheathless systems and the railway system, and the support issue is overcome by using guide extenders and anchor balloons and trap balloons to allow and facilitate the success in the complex case. All right, so changing gears a little bit with the next case. This is transradial access in an anomalous coronary PCI. These are always interesting because you may or may not know that the patient has anomalous coronaries when you go into the case. But this was one where we had a 70-year-old morbidly obese female with a BMI of 47 that was referred for progressive angina. So in a patient that's morbidly obese, this is a typical radial case for us because of all the access-related issues from a femoral access in an obese patient and body habitus causing the issues with bleeding in these patients. So this was done radially, but she had a prior history of aortic stenosis, status post-mechanical aortic valve replacement 10 years prior. So we know that this patient already has had an open chest, which again elevates perhaps the complexity of the diagnostic procedure a little bit, modifying anatomy. The stress test demonstrated significant anterior wall ischemia, and she was then scheduled for the angiography. So like I said, this was done radially. And the reason for showing you this case is to show you a very unique situation of a single coronary artery where the entire left main and the left coronary system and the right coronary system arise from a single ostium. And so this is a very unique case that we published that was engaged with an Amplatz left catheter for the diagnostic procedure. And sadly, as the stress test demonstrated with anterior ischemia, she was found to have a lesion in that proximal LAD segment denoted by the arrow in that C panel. And so the question is, would you then continue with the radial access in this complex anatomy in a unique anomalous coronary case, or would you then switch over to a femoral access to provide greater reliability in how your catheters sit? So just to challenge ourselves, we decided to try to do this procedure from a radial approach initially. So this is, you see that there's a femoral catheter here to look at it initially. But we ended up doing the whole case from the radial approach. This is a guide sitting, the Amplatz left guide actually sitting from the radial access with a wire across the lesion in that proximal LAD. We even did an IVUS to evaluate the size of the vessel because it appeared to be extremely large, and to appropriately size the stent for this vessel, and treated it successfully with a great result as shown here in this in the left and right panels. The left panel is the pre-image and the right panel is the post.
Do you consider in this one, as well as osteal lesions or other ones that are tricky, to stiffen your wire, or do you always stay with the same wire?
Yeah, that's a great question. I think in these kinds of cases where you almost saw that guide flipping in and out of that ostium, which shows you that you have very little support. You try to get as much support compensation with the addition of a wire and a guide extender. And so that's what we tend to use. I can't recall exactly in this case what was done, but I would typically use a soft wire to navigate the tortuosity into the distal vessel, and then use a support catheter to exchange the wire for a stiffer supportive wire. And then on top of that, perhaps even use a guide extender to sit further into the LAD to support the delivery of the equipment.
This is also a good example of using imaging. You're getting excellent diameters and apposition in measuring these vessels, these target vessels. It takes extra time, but you're getting a much better result and probably a better long-term result for the patient as well.
Absolutely. I think we have a lot of data coming out about adjunctive imaging, intravascular imaging in these patients, and improving outcomes if you have good stent apposition and expansion, and getting a minimal luminal diameter that is greater than 90% of what you started off with. And so we tend to use a lot of imaging in our, as an adjunctive tool in these cases. We'll switch gears here now into the extra coronary space, and we'll perhaps take a journey from head to toe here. So we'll start off with carotid interventions. This is transradial access in carotid interventions, which is which may have been in the past an avoided access for carotid interventions because you have limited window of error. But here is a 62-year-old male that presented with a transient ischemic attack. CT angiography was performed, which did not reveal any focal infarcts, but confirmed an 80% stenotic lesion in the right internal carotid artery. He was also noted to have 60% stenosis of the right subclavian artery distal to the right common carotid artery, and then was scheduled for carotid angiography and stenting. And so in a patient like this, where you have right subclavian artery stenosis, just distal to the right common carotid artery origin, it becomes tricky to use the right radial artery as the access point because you would have to traverse the stenosis and allow the catheter to navigate around it into the common carotid artery if this were to be done transradially. So you have the option of then using the contralateral radial access, which is what we decided to do in this particular patient, using the left radial artery access as our access point. So what you see here is an aortogram being performed to look at the arch anatomy. You'll see the tortuosity of that subclavian on the right side, right around the origin of that right common carotid artery, and also the borderline lesion that you see there into the subclavian. And you'll see that this is a type 1 to type 2 arch that allows you to have, perhaps reasonable access from a femoral approach to be able to do this case. But again, this case is here to demonstrate that it can be done safely from a radial access. As you know, carotid interventions only require 6 French catheters. Both the balloons, the stents, and the distal embolic protection can all be delivered through a 6 French sheath. And so what we have here is a wire coming down the left subclavian into the ascending aorta, looping at the aortic valve and going back up into the right common carotid. And what that provides is amazing support, as a matter of fact, to be able to deliver equipment as it sits on the aortic valve pointed straight up right into the right common carotid artery. And so the wire and the left panel, and you see the sheath has traversed that supportive wire. We typically use a stiff glide wire in these cases, position in the right external carotid artery, and take a 6 French shuttle sheath or destination sheath over that into the right common carotid artery. And so you see the pre-lesion as demonstrated by the arrow in the left panel is the original lesion that we were dealing with, and then the right panel shows you the result post angioplasty and stenting with distal embolic protection that was done successfully from the left radial approach.
That's a good case. This is another way to maybe show the railway. Railway can be done also with the 7 French Cordis guides, the 7 French GR4, or the XBLAD. Can also give you the same access. I'm impressed on your access from the left radial across the arch. I like that. That was very good.
Yeah.
I think that was really good. I think these patients will benefit. There's less irritation to the arch. There's less risk for embolization. Alternately, if you go back to the pre-picture, if you go back a few slides, and you can show the tortuosity of the common carotid, that one would be a good setup if it weren't for the 60% subclavian, because of that loop, you'd be able to get your railway and your JR4 all the way up with your stiff glide. But that's a wonderful case. Showcases all of our new abilities and techniques.
Exactly. And what we've found in our experience is that, as you mentioned, there's less manipulation in the aortic arch as opposed to coming from a femoral axis. What we tend to do is do a lot of clockwise and counterclockwise rotation in the arch as the femoral sheath is hugging the outer curvature of that arch. And if it is a patient that has aortic atheroma, which a lot of these patients that have atherosclerotic disease in the carotids do, we are potentially embolizing those atheroma and debris down the aorta. And so there's less manipulation, and it's a lot more elegant coming from a radial axis in some of these cases. And so we've had a variety of these where we've gone just radial off the bat, and others where we've actually gone femoral first and failed to engage in a type 3 arch or have enough support in a type 3 arch to be able to sit a sheath up there. And then we've switched over at that point to go to radial, and then you have all the support in the world by the catheter looped at the aortic valve. So I actually have some data that was published. This is looking at transradial approach for carotid artery stenting. This was 300 plus patients that were looked at as a case series and published in CCI that looked at the complications at 30 days going from a radial access approach. And you'll see that again, this is not a randomized comparison. This is just looking at the transradial axis. And you'll see that the comparison of complications or adverse events are extremely low. The only thing that sticks out is that 7% of radial artery occlusion. And the question is, can we get better at that as we go to sheethless systems and using the railway system, as you mentioned, by providing less trauma with a smaller arteriotomy at the access site. But this is, again, data that's evolving on using alternative access sites for even carotid interventions. So next we'll go over to an upper extremity intervention and using transradial access. This is a 69-year-old male with history of hypertension and COPD, presented with shortness of breath and dizziness with use of his left upper extremity. He was noted to have unequal blood pressures in both the upper arms with a 35 millimeter blood pressure gradient and a lower blood pressure in that left upper arm. So with the combination of symptoms and dizziness and the clinical demonstration of subclavian artery stenosis, he was scheduled for a left subclavian artery angiography. And what you see here is a complete occlusion of the left subclavian artery with a left radial artery axis demonstrating that occlusion, which was crossed with a single access from the left across into the aorta, and then balloon angioplasty and stenting performed from the radial axis. Now, sometimes these complex occlusions may require dual access, requiring you to come from the radial and femoral axis, but being able to do it from the radial alone, again, alleviates the issues that we have with femoral access, both in immobility of the patient for a prolonged duration and also with bleeding complications that are definitely higher with femoral access.
That's a great case. Access, sometimes when they don't have a palpable pulse, we use Doppler to find it. Mm-hmm. And even though the vessel is small and it's scary to the operator, once you recanalize that vessel, it'll plump up. Beware of the placement of the ostium. Mm-hmm. So you're imaging already the arch. Mm-hmm. And beware of pushing the stent even higher. I like that result. Angiographically, and it's a safe result. Rupture of the pedicle in an area where there's no support is an instant bleed. That's a perfect result.
Yeah, we're pretty happy with it. And so just going down the body, again, so we did carotids, we did upper extremity, subclavian stenosis. This is renal artery interventions using transradial access. This is a 64-year-old female with history of diabetes and hypertension that presented with uncontrolled hypertension on 3 antihypertensive medications. The patient was also noted to have chronic kidney disease with a creatinine of 2.4. So all suspicious for the patient having renal artery stenosis. So the patient had a renal duplex ultrasound which revealed elevated velocities in bilateral renal arteries suggestive of severe stenosis in both the renal arteries, and was then scheduled for a renal artery angiogram. Again, with the creatinine being elevated with chronic kidney disease, with utility or utilizing small amounts of contrast to do the procedure. So this is a transradial access to engage the left renal artery, showing again in panel A the tight ostial stenosis in the left renal artery, which was angioplastied with the balloon and stented across that ostium as demonstrated in the panel C with a great result, all from a left radial artery guiding catheter that was used for the entire procedure. And then flipping over to the right, the stenosis on the right side was in the proximal vessel, not at the ostium, which was wired again with the same guide from the left radial artery axis, ballooned and stented as shown in panel F with a great result.
Yeah. The renals, the mesenteric vessels were all made for radial access. You don't have to worry about the acute angle from the femoral artery, the window washing and the wiper effect of all the atheroma. And it's very gratifying, both for the patient and for the operator.
Absolutely. Yeah, I think we've had plenty of those cases where we've unfortunately chosen to go the femoral route, and then you struggle with delivering equipment because it just kicks the whole system out because of that downward takeoff of the, as you mentioned, the renal arteries and the visceral arteries from the aorta. And so, as you said, the radial artery is a great access point for these cases. All right, moving on down the aorta. Now we're getting into the distal aortic interventions. And these, again, in the peripheral world are getting into a more complex subset of interventions because it involves the aorta, the risk of complications, rupture, all of those increase as you're working in the aortic space and the iliac space. But this is a 72-year-old male that presented with 5-year history of progressive lower extremity claudication that unfortunately had not sought any sort of treatment, but had progressed to the point where he was unable to ambulate even a block, and which is when he came in to get evaluated. CTA angiography at that time revealed a distal aortic occlusion and reconstitution of the bilateral common femoral arteries. So we knew going into it that we were dealing with a distal aortic occlusion, and he was scheduled for a peripheral angiogram. And so again, this is again the complex subset where you may need multiple access points to succeed in this case. But we tend to start with the radial access in these cases, or if it's a really tall patient, maybe you have to move it up to a brachial access depending on how far down you have to go. But radial is usually sufficient in the distal aortic and the proximal iliac interventions. So I'll show you the film. It's the panel on the left shows you that distal aortic occlusion. Thankfully, it's under it's infrarenal occlusion, and so not worried about compromising the other visceral vessels. And we were able to traverse that occlusion from that left radial artery access, where I was able to take a stiff glide wire looped with the support catheter across the occlusion and re-enter the true lumen in the common femoral arteries on both sides, which allowed us to stent, balloon and stent across that entire segment, all from the radial axis. Now, as I mentioned earlier, there are cases where you're not successful doing that, and you may require subsequently a smaller access using ultrasound guidance in the common femoral artery to just allow wire crossing, which can then be externalized and then still treated from the radial access point to minimize the bleeding risk by upsizing the sheets in the femoral arteries.
It still is a win, even if you have to convert, I agree, to femoral, because you're getting a better approach from the top down, less chance for subintimal dissection from the bottom up. You're always getting direct visualization of whatever you're doing in the groins. And like you said, once you traverse or you can snare, you're getting better or lower diameter of the sheaths in the groins. It's just really much better to use radial, even if you can't get everything, but this was successful from the radial approach. But sometimes even with the hybrid procedures, it's still a success.
Yep, I totally agree. And so we, again, try to focus on utilizing the radial access whenever we can, and then supplement that with additional access as needed for these cases. And thankfully, in this particular one that was demonstrated, we were successful with radial alone. And now we're getting into the lower extremities where it can get challenging. So this is a transradial access in a lower extremity intervention. This was a 75-year-old male with a history of peripheral arterial disease, had a known aortobifemoral bypass, presented with severe lifestyle-limiting claudication. He had ankle brachial indices performed as an outpatient, which was severely reduced on the left side at 0.65, which demonstrated severe disease in that left leg, and he was scheduled for a peripheral angiogram. And so what you see here is a aortofem bypass that terminates at the common femoral artery in the left panel. Panel A, and you see an occlusion of the ostium of the SFA with just filling of the profunda on that left side. In panel B, you see that it was crossed with a wire and support catheter, and then we are able to get long balloons, long shaft balloons that can go to the distal SFA. It all depends on where the vessel reconstitutes, and was treated with just balloon angioplasty and with an adequate result in that right panel. When it comes to stenting or using adjunctive tools of atherectomy, you can be limited by using a transradial access, depending on the height of the patient as to how far you can reach with some of these devices. We've used hybrid approaches in these cases as well, and there's a big movement into using a combination of transradial and transpedal to do lower extremity interventions. So just like using the radial artery as the access to minimize complications from bleeding from a femoral approach, you can use a dual approach from transradial and transpedal to be able to traverse and use a shuffling of both access points to deliver the equipment needed to complete the case for complete revascularization. And so there's a variety of techniques that are now available, and utilizing, again, the sheathless systems, railway system, you're able to use these smaller access vessels to do complex work.
That's a great case. The ABFBs are unforgiving and going over the horn. Just somehow they don't accept from femoral to femoral approach. So another reason to start with radial first. And that short nipple allows you to go straight down. I like the way you got it right at the ostium as well. And good, it's a good lumen too. You didn't get a 4, you got between 4.5 to 6.5 right there.
Yeah. Yeah, so we were fortunate, and as you said, these aortobifem bypasses are very difficult to, depending on the angulation, very difficult to get from a contralateral femoral approach. The other subset of patients that are difficult are the EVAR patients that have had stent grafts in there to cover their AAAs. Those are very difficult to get from a contralateral approach depending on the type of graft used. And so these are cases which can be done transradially and maybe even with the hybrid approach with retrograde popliteal or transpedal access.
I agree. There's only one company that preserves the aortoiliac bifurcation. All the other companies really take it away. They take that off the table, our femoral approaches, because it's just not there anymore.
And we tend to have a lot of proximal disease and high BMI patients, and so that takes away the antegrade femoral approach as well in majority of our patients, and so that access goes away as well. So you're limited in what your access points are, and they tend to be the distal access points with transpedal and transradial. So here's a breakdown. We went through a variety of peripheral interventions, endovascular cases from using the transradial access. This was a nice summary of cases that was published in the Journal of Vascular Surgery, looking at categories of interventions that were performed from the radial access in peripheral cases in Table 2. So you'll see that there's a good number of interventional cases done, about 80% of the cases that they did from a transradial access, and that included a variety of different things with angioplasty, stenting, even some atherectomy, although, like I said, you're limited by the length depending on the type of atherectomy device that you use. So majority of them tend to be angioplasty and stenting. In Table 3 at the right bottom panel, you see the location that was treated in this patient subset in the cohort that was published, and you'll see that there's a good number of patients that were aortoiliac and femoral, and there's a diverse group of patient or vascular beds that were treated, but majority of them were that aortoiliac and femoral vascular beds that were treated from a radial approach successfully. So we come to the end of the cases that I have to present, and the question that you have to ask yourself as you look through these cases, and as we've demonstrated the utility of radial access in a whole spectrum of cases, from simple acute MI cases to complex coronary chronic total occlusions, to bifurcations, to carotid interventions, to lower extremity interventions. Is your cath lab a radial first cath lab? And so I think I will stop there.
Yes, that's a wonderful presentation. Even if they come back for a staged procedure, if their initial procedure is radial, they still walk out of the lab in 2 or 3 hours while you're planning all of this, and the radial artery can be stuck again quickly, soon, efficiently, maybe a little higher stick, or if there's any problem with the contralateral approach. But even if they come back, it's still much better, and the patients are actually asking for this now. They're saying, I want it from the arm, and it's going to be pushing us to the next level. It's a wonderful presentation. Thank you.
Oh, thank you. Thank you for having me.
And thank you very much for participating and listening to us. I hope you've gained insight. Maybe you can add to our experience.